Welcome to the A to Z of menopause. I'm Anra, nurse practitioner and owner of Lowena Health. And over the next 26 episodes, we are going to break down exactly what happens to your body during the menopause transition. And more importantly, what you can do about it. We're starting right out of the gate with the letter A, which stands for atrophy and androgens. We're going to be talking about your vaginal health and your libido. These are the symptoms that many women suffer with in silence because they feel embarrassed to bring it up to their doctors and they don't feel comfortable talking about it. So today we're going to take away the taboo. Let's start with atrophy. For years, the medical community called this vulvovaginal atrophy, but today we use a much better term, Genitourinary Syndrome of Menopause, or GSM. So why the name change? Because the loss of estrogen doesn't just cause vaginal dryness. Your vulva, your vagina, bladder, and your urethra are all packed with estrogen receptors. So when your estrogen drops during perimenopause and menopause, the tissue gets thinner, drier, and less elastic. This leads to a whole syndrome of symptoms. You might experience painful sex, itching, or burning, but it also causes urinary symptoms like having to run to the bathroom constantly, pain with urinating, recurrent urinary tract infections, otherwise known as UTIs. This is the important thing to know about GSM. Unlike hot flashes, which usually eventually fade away, GSM is chronic and progressive, and it does not get better on its own. The good news is it's incredibly treatable. With the mild symptoms, we can use non-hormonal vaginal moisturizers and lubricants. But for moderate to severe symptoms, the gold standard treatment is vaginal estrogen or vaginal DHEA. Many women are terrified of estrogen because of breast cancer fears or blood clot risks. But here's the clinical truth. Vaginal estrogen is not the same as systemic estrogen, like a pill or a patch. Low-dose vaginal estrogen stays local to your pelvic tissue, with minimal systemic absorption into your bloodstream, which means it's exceptionally safe and even safe for many breast cancer survivors. Now let's move to the second A, androgens. When we say androgens, we're mostly talking about testosterone. And yes, women make testosterone too. In fact, before menopause, you have more testosterone circulating in your body than estrogen. Testosterone plays a major role in a woman's sexual health and desire. During perimenopause and menopause, your ovarian and adrenal function shifts and androgen levels drop. For some women, this drop leads to a condition called HSDD, otherwise known as hypoactive sexual desire disorder. HSDD is defined as a persistent lack of sexual desire or sexual fantasies that causes you personal distress. If your libido is low and you're perfectly happy with that, it's not a disorder. But if the loss of your sex drive is bothering you or impacting your relationship, it is a medical condition and we can treat it. You might see functional medicine clinics promising that testosterone will fix your weight, your brain fog, and your energy. But according to the Global Consensus Guidelines and the Menopause Society, the only currently evidence-based reason to prescribe systemic testosterone to a postmenopausal woman is to treat HSDD. If your doctor suggests treating or testing your hormone levels to diagnose a low libido, politely decline. The medical guidelines clearly state that total testosterone blood levels should not be used to diagnose HSDD. We diagnose it based on your clinical assessment. We only check your blood levels before starting therapy to get a baseline and then during treatment to make sure it's physiologically in a safe range. So how do we treat it? The recommended method is transdermal testosterone, meaning a cream or a gel applied to the skin. Because there are no currently Health Canada approved testosterone products specifically made for women, we often carefully prescribe a fraction of what males are prescribed, so about a tenth. We generally don't recommend testosterone pellets or injections because they can cause your levels to spike way beyond a normal female range, which can lead to side effects like acne, hair loss, and voice changes. The goal is to bring you back to the levels you naturally had before menopause, not to turn you into a bodybuilder. To sum up the letter A, vaginal dryness and lost libido are not just part of getting older that you have to put up with. Local estrogen and transdermal testosterone are safe, evidence-based tools that can dramatically improve your quality of life. If this resonated with you, hit the like button and subscribe. In our next episode, we are diving into the letter B, and we are tackling the big three: bone health, brain fog, breast cancer. See you soon.